right, everyone, we'll get started if everyone's seated. So, good evening. Welcome to the Snyder Institute's Mini Medical School Lecture Series. We are pleased to host a presentation and discussion this evening on the topic of liver cancer. Before we get started, I would like to go over a few housekeeping items. There will be two parts to tonight's program. First, our presenter will speak for about 40 minutes, and then we will open the floor to audience questions. Following the Q&A session, there will be an informal reception for those of you here in person. You're welcome to ask your questions at any time during the presentations using Slido. To access Slido, you can scan the QR code or manually enter the event code Snyder MMS into the participant field on the Slido website to post your question. Questions submitted to Slido will be viewable to all audience members, and participants can upvote the questions they like the most. Now on to more specific housekeeping items. For those of you that have joined us online, if you lose your internet connection and drop out, you can return to this session using the same Zoom link you used to join us now. If you experience any technical issues, such as you cannot hear or see the presenters, please email snyder@buxa.com and our team will do their best to support you. For those of you here in person, we now ask that you switch your cell phone to silent. Please note this event will be audio recorded and the recording will be posted on the Snyder Institute website and YouTube channel. Private recordings are not permitted. Now to formally begin tonight's program, the Snyder Institute at the University of Calgary's Cumming School of Medicine, located in the heart of Southern Alberta, both acknowledges and pays tribute to the traditional territories of the peoples of Treaty 7, which include the Blackfoot Confederacy, comprised of the Siksika, the Piikani, and the Kainai First Nations, and the Tsuut'ina First Nation, and the Stoney Nakoda, including the Chiniki, Bearspaw, and Goodstoney First Nations. The city of Calgary is also home to the Métis Nation within Alberta, including Nose Hill Métis District 5 and Elbow Métis District 6. Now, without further ado, I would like to introduce our speaker, Dr. Mayur Brahmania, who is a clinical associate professor in the Department of Medicine at the University of Calgary. He practices in hepatology and transplant hepatology with special interest in the quality of care in patients with cirrhosis and liver cancer. Welcome, Dr. Brahmania.
Thanks, Hannah, for the introduction and the invitation, and to the organizing committee. And thank you for everyone coming out tonight. I know it's sometimes difficult to come out for an evening presentation, but hopefully you'll gain some insights and facts about liver cancer that you did not know about coming into today. So on the right side, I think many of you know David Letterman, stand-up comic for the late night show for over 40 years. And so I thought we'd make this presentation a little interactive and have the audience participate throughout the talk today. And and so with that being said, I think the core objectives that we want to talk about today. Okay. I'll talk about my complex disclosures and inclusions. So there are no copyright infringements in this presentation. We didn't use any generative AI to construct the presentation. These are my consultancy fees. Roche, Merck, AbbVie, Gilead, and I said the pharmaceutical companies that help with research endeavors that we partake at the University of Calgary, and specifically related to liver cancer. None are going to be relevant to this presentation. I'm aiming to use first person first and inclusive language in this presentation. And if you notice anything that could be improved, please email me there. There's my personal email at the University of Calgary. And lastly, I cannot provide any medical advice to you. Please contact your own doctor or nurse if you have personal questions. Certainly, if there's other general questions that would be applicable to the wider audience, I'm happy to answer those for you today. So really, at the end of the session, I hope you'll be able to get a better understanding about the epidemiology of liver cancer, and then explain to your friends or colleagues at work or at a coffee shop how we can prevent, screen, and treat ACC. And so for me today, it's a way to amplify my voice to our patient population and spread the news about this deadly disease, which we'll talk about. So when Hannah asked me to put this presentation together and talk about the mini med school, I was a little confused at first because I didn't know how detailed I wanted to be or keep it broad. So I chose something right down the middle. But it actually brought me back to my days of medical school, and I thought, well, what epitomizes medical school? And the first thing that came to my mind was actually a lot of exams. Like if you go through medical school, you're writing exams every 4 to 6 weeks, and you become a professional test taker. So I want you to be a part of that a little bit as well today, and that's why this talk is going to be partly about testing your knowledge and we'll see how the audience does. We have some participants online as well too. So without any ado, I'll give you guys a start, and we'll start with the warm-up question. So this is what I was talking about. It's quiz time. So the first quiz question here, and this is just true and false. So we're going to make it easy. If you have a cell phone, you can scan this QR code here. And the question is, the liver is the largest organ in the body. Okay, we'll give it a few more seconds here. Okay, yeah, so 1/5 of the audience has chosen false. So around 80% of people believe that the answer is false. And the answer is actually true. The liver is and here's the trick. So it's the largest solid organ so in the body. So that's where the kicker is here. So just to give you some background before we bring in this presentation, it's the only organ that actually has in the body with a dual blood supply. So if you look at the picture on the right there, you can see the portal vein, which brings blood from the bowels, and then the hepatic artery, which takes blood from the heart. And so you have a dual blood supply of the liver, supplying both the right and the left lobe. So you have two parts of the liver there. And we'll talk about that a little bit later. And hopefully, or now you do know that it actually has over 500 unique functions in the body. And it is only one of the only organs, well, actually the only organ that can regenerate. And so why is that important? Well, when you look at all the functions that your liver does, first they can detoxify. So the liver metabolizes toxins. So you'll hear about in the social media about liver cleanses and things you can take, and your body does that on its own actually. So you might not need any of that. It filters blood, as I explained to you. There's a dual blood supply, so it's a cleaning factory. It's a manufacturer, so it helps with producing energy that the rest of the body can use. It's a storage facility, and it makes bile. So that bile helps digest your food. Shortly after you eat, bile starts being produced and breaks it down into the micronutrients that your body absorbs for the building blocks of your body. And then most importantly, I would say that it helps regulate your temperature, not only your brain with the hypothalamus, but the liver can help regulate your body temperature. So with that being said, when you have a healthy liver, and we're all born with mostly all of us are born with a healthy liver, over time you can develop chronic liver disease. And chronic liver disease can be from a variety of etiologies. I put some common ones that we see nowadays. So alcohol use, metabolic syndrome, such as those with diabetes, hypertension, or cholesterol, obesity. If you have viral hepatitis, like hepatitis B or hepatitis C infection, and then there's autoimmune disease of the liver that can start damaging your liver. And over 10 to 20-year period, you can go from the state of chronic liver disease to what we call cirrhosis. Cirrhosis is synonymous with stage 4 liver disease and stage liver disease, but the proper terminology is cirrhosis. And if absolutely. Yes. Is that better? And just those ones in the middle. Yes, theater stuff. So as I was mentioning, you can go from the compensated cirrhosis to what we call decompensated cirrhosis. And so those are the development of complications such as variceal hemorrhage, ascites, where there's fluid that retains into your stomach, and encephalopathy, where you can have confusion in your day-to-day activities. Once you develop decompensated cirrhosis, that's where you're more prone to developing liver cancer, where the risk is about 5% per year. And it's not accumulative, it's per year you have a 5% risk. And other complications from cirrhosis. So that includes further bleeding. You can have problems with regulating your potassium and sodium in your body. You can have kidney damage. And ultimately, that can lead to death or the need for a liver transplantation. So most of our patients kind of cycle through this cycle. And our goal really in hepatology, not only is to look at the upstream drivers of chronic liver disease, but also to treat the patient at various stages along their journey. And then in between there, you can see that, you can have hospitalizations and death. And so we really want to work upstream and tackle this issue. And really that's why I agreed to do this, because I saw that the audience is here, and it really gives us a forum where we can amplify our voice around this deadly disease. So the second question I have for you here today is liver cancer, and we will use hepatocellular carcinoma, or HCC is the short form, but often we use liver cancer. But for this question, so HCC is a top 3 cancer killer worldwide. What does the audience think here? Leave the QR code up for a bit. So remember, we have lung, breast cancer, colon cancer, prostate cancer, skin cancer. Okay, this is good. We're seeing patterns here. So this time the audience has chosen roughly 80% have said this. The answer here is true, and the verdict is true. So as I was mentioning, hepatocellular carcinoma can develop in 30% of patients with cirrhosis, and it is the 6th most common cause of cancer, but the 3rd leading cause of death worldwide. And so this is not lost in all of our research papers. You can see in 2016, this is from JAMA, which is a well-respected research magazine. This is from the middle one is from the British Medical Journal. And then this one is in Cancer, talking about how liver cancer is on the rise, and we should take note of that. And here's a paper from JAMA Oncology looking at the predictive death for liver cancer, or HCC, by the year 2040. And so I've put in red box there, and I'll read it for the audience here. So lung cancer will continue to be the #1 leading cause of death, mostly due to cigarette smoking. pancreatic cancer is set to overtake the deaths, and then liver cancer, 41,000 deaths. And then this is surpassing colon cancer, which is around 34,000 deaths. So the point with this slide is you hear a lot about lung cancer, colon cancer, breast cancer, prostate cancer screening, but you never hear about liver cancer screening. And here you are with the data that's showing that liver cancer is on the rise. And this is because chronic liver disease now has actually become a national top 10 cause of death. And you won't hear about this. And so we do have effective treatments for hepatitis B and hepatitis C, where we didn't maybe 15, 20 years ago. And now with the obesity epidemic and rising alcohol sales, you can see that these are the major drivers of cirrhosis and its complications, along with liver transplantation and cancer. And here on the right side is a graph here showing the various etiologies of patients that are on the wait list. And so you could see, you know, the green and the blue here, which are alcohol and NASH or fatty liver disease, are increasing, and then the other etiologies are decreasing. And so this is becoming a big problem. And when you look at our hospitalization, this is an American study, but really applicable to Canada as well. This was a big study in Texas with over 90,000 people here. And you can see that the hospitalization rates are steadily increasing over time. And we even looked at our data from Alberta this past year. So last year, patients with liver disease were responsible for over $250 million worth of hospitalization. So an average patient with liver disease will be in the hospital for about 10 to 14 days. And when you look at an average cost of a hospital bed per day, it's about $1,000. So you can see that quickly that a hospitalization could cost $15,000 to $20,000 per stay. And a lot of that you might ask yourself is well, what's really going on here, and why can't we do better? And I ask myself all the time. And so we wrote this article in the Canadian Liver Journal a couple of years ago, looking for, we called the priority actions to elevate liver health in Canada. And you can see that it's very complex. So what we want to do, as I was mentioning before, we want to look at early identification of patients so we can alter the trajectory of the disease. And that we need interventions at various stages of a journey of a patient with chronic liver disease that are frankly fragmented or missing. And so when you look at cancer screening program like breast cancer or colon cancer, you know, for colon cancer, when you're 50, the province will email you a FIT card, and you know, you return that card. If it's positive, you'll be on to another screening test. If it's negative, you repeat it in 2 years. Breast cancer, females, you start being identified around 40, and you're called in for an ultrasound, and then you keep going. Whereas liver health, there's no priorities for our central government, and in Canada, I would say as well. And this becomes very difficult. So if you look at the curve on the right, we look at interventions that we can do. So we can break it down to things that we can do easy, that have high impact, right? Which is what you would want to do. And that's like the top right. And so some things that we do in the community are tests that the doctor can order, and then also fund for elastography or testing if you have advanced disease. But when you look at implementation or strategies that are very difficult, and if you look at the bottom left here, so we need increased research for social determinants of health. We want to support educational programs for our youth, right? And then endorse initiatives for our primary care providers. But there's other things like improving food insecurities for many patients in the setting of fatty liver disease. And those are very difficult to accomplish. And again, we rely on research, clinical education, and then patient partners that we work with to help tackle these things. So here's a controversial question that many of you may or may not agree with, but vaccines and treatment for certain liver disease can prevent liver cancer or HCC. Great. So about 80% of the participants have picked true as the right answer. And the answer is, before that, I would say it is true, but here we are. It's Robert Kennedy, as many of you probably know, who now has recommended against the hepatitis B vaccination in childhood. And so do we agree with that? You might have your own views and opinions around that, but what does the data show? And so this is the WHO recommendation. And so this is probably one of the largest natural history studies that we have in liver disease. And really, it began with Taiwan developing a national strategy in 1984 to vaccinate during childhood. And what they actually accomplished was that with this vaccination series, they were able to prevent hepatitis B in children and then all the long-term complications from there from about 17% to 2%. And so what does that ultimately do? Well, that ultimately, and you can see in the graph here, this led to about a 80% reduction in the formation of liver cancer. And so you can see the HCC or liver cancer incidence in those patients that were born before 1984 and then afterwards, and you could see a dramatic reduction in there. And then in parallel, there's a reduction in mortality, which is pretty common sense to talk about. And so even for hepatitis C, we know that now there are treatments anywhere from 8 to 12 weeks with cure rates over 90%. We know that if we treat hepatitis C, it can reduce the risk of liver cancer as well. And so the argument in the initial stages of hepatitis C treatment was that, you know, these drug companies were selling these expensive medications for $60,000. But as I was showing you before, when we prevent and we act upstream, no matter what the cost is, you can prevent downstream complications and downstream costs. And in addition to having a cure for the patient and saving healthcare dollars, you see an improvement in the patient's life as well. And luckily for hepatitis B, we have therapy that can control the infection. And we at the University of Calgary and my colleague, Dr. Coffin, is working on a cure for hepatitis B as well. And we do many studies here that are phase 1, 2, and 3, which are pretty robust and exciting times in liver disease for sure. But did you also know that black coffee can reduce the risk of liver cancer and hepatitis C and chronic liver disease as well? And so 2 to 3 cups of black coffee, so no sugar, no sweeteners, no cappuccinos or mochas or any other type of drink that you might see at Starbucks, but pure black coffee can reduce the risk there. So there is a benefit of drinking it. But most importantly, as I was mentioning earlier, alcohol and obesity have really taken a toll on the liver from a population standpoint. And so when we look at, again, the rising causes of liver cancer and even the cause of liver transplantation, they're mostly nowadays related to alcohol and obesity. And here you can see the curves here kind of moving upwards, and then the hepatitis C curve moving down, because again, we have cures for that. So the fourth question for you here today would be around alcohol. So kind of giving you a hint already, but you don't have to drink alcohol to get HCC, liver cancer. Perfect. So I think, 98% have said true. And that is, so here's the worldwide incidence of liver cancer across the different regions of the world. And you can see that the cause of liver cancer really depends on where you live and related to culture, race, ethnicity, and the sort here. So in North America, hepatitis C is a big driver. And then as I was mentioning, NASH or fatty liver is a big driver of it. Whereas if you go to places like Asia and you look at the graphs over there, you can see the etiologies are more related to viral hepatitis, such as hepatitis B, and hepatitis B is the most common cause. And alcohol and fatty liver are less. And you can see the different distributions around the different countries. You look at Africa, it's more viral hepatitis. And so, if you look to the east, you could generally say it's viral hepatitis. If you look to the west, it's mostly related to alcohol and the obesity epidemic. Okay, moving along pretty well here. So you can still feel well and have liver cancer. True or false? Okay, great. Everyone's doing really good here. So about 90% of people have said this is true, and you're correct. Most liver cancers are actually asymptomatic. One of my teachings to my residents and fellows is the best part of liver disease is that you never feel it. The worst part is you feel it when it's too late. And so the typical changes of having pain in the right side, going to the back, you might have weight loss, loss of appetite, and you're feeling full after a meal. Sometimes you can get bulging of your flanks, so buildup of what we call ascites. You can see what we call jaundice or yellowing of your eyes. Fatigue is very common. You can have digestive issues such as nausea, vomiting, pruritus or itching, and then easy bruising or bleeding. And that's one of the telltale signs of having some impairment in your liver function. Really, when you get to the advanced stages of liver cancer, that's when you start seeing the systemic effects of it. So you can have mental changes, you can start feeling a difference in your mood, confusion, you can have fever that you cannot break with over-the-counter medications. And then you can start seeing swelling in the legs. But most of the time, our liver cancers are actually caught incidentally. Someone's feeling well, they go to the emergency room and some type of imaging is done, which leads to a CT scan or an MRI, and then a diagnosis is made through there, which is unfortunate, and why we're talking about the upstream kind of capturing of patients when we can find them early and get into programs, which I'm going to talk about next. So here's a question for you. And people with hepatitis B infection can get liver cancer even without cirrhosis or severe scarring. Can you change the question? Yeah. Good, that's amazing, great. Everyone's doing really well. So about 90 to 95 percent of you have thought that true is the right answer, and it is true. So we do have formal recommendations on people that should undergo what we call surveillance or screening for liver cancer. And so there is a difference in what we call screening and surveillance. And so screening means who are the patients that we should target for screening. And this is the population here. So if you have cirrhosis of the liver, you should be screened with a test. If you have hepatitis B infection, you should be screened. If you have hepatitis C, alcohol, cirrhosis, and then particular to hepatitis B, we have different stage criteria. So if you're a male from an endemic country, you would start screening at 40 years old. If you're a female, you would start at 50. If you're from Africa, usually you start at age 20, or some people are saying now even 40. And so we do have a patient population that's well defined and who we should be screening for. However, the question is it worthwhile to screen these patients? And this is where we enter into the definition of surveillance. So what are we doing about those patients that should be screened? And is it a benefit to society to do that? In colon cancer, breast cancer, we've decided as a society that it's worthwhile to catch these cancers and screen for them so we can intervene early and provide some type of treatment that will hopefully allow a patient to live longer. And this is the same with liver cancer. Unfortunately, we've only had one study from 2004 back in China looking at patients that were eligible for screening, and they were randomized. So equal chance of getting an ultrasound to screen every 6 months or get nothing. And you can see that the screening rate of those that underwent it was around 58%. And you can see that there was an improvement in mortality from liver cancer by about 37%. And your survival rate was greater than if you didn't have surveillance. And so what's hampered our society right now is that nowadays you couldn't conduct a study like that because it would be unethical. So we go by this study as proof, even though it was done at a single center in Asia. And so it might not be totally relevant to the North American experience. And so what does the National Liver Cancer Institute say? Well, they've conducted a meta-analysis and they felt that there isn't any improvement in mortality from liver cancer screening. And they cite that there is lead time bias. So this is what is considered an improvement in survival of a diagnosis made early in the disease course. And then length time bias, where you get earlier detection of a slow growing tumor with better biology. And did that result in better outcomes? And so that really, that was from 2014. And our field that has been in a state of flux regarding that. But generally, it's thought that you have an ultrasound plus what we call alpha fetoprotein, which is a blood test biomarker. It's relatively cheap. When you look at tests for screening, as I was mentioning, for colon cancer, they'll give you a card, which is very cheap to do. An ultrasound is relatively cheap. And, when you want to roll these out, you think about, is it cost effective? Is it easy to use? And would the public agree to having this done? And generally, we think that these types of tests are actually pretty good, at least to roll out into society. And so when you look at the combination of an ultrasound plus this biomarker or blood test, you can see the sensitivity of it is around 60%. So and the specificity is about 92%. So specificity is how good is that test of ruling in liver cancer, where sensitivity is determined as how good is that test ruling out. And so you can see with the different tests here, as I've mentioned below, including genetic testing, other blood-based testing, there's a pro and con with every test. And so we have, as a society, have to decide, is this worthwhile? Recognizing that if you have a test that only about 61% good, is that good enough? And we generally believe that it is, especially when you combine it with the blood test. Now, as I was mentioning, when we have these tools for surveillance, we want to look at the benefit, so early liver cancer detection. We know that patients that are detected earlier are more often to receive curative type of treatment, which inevitably leads to improved survival. Now, what are the harms to society? So obviously physical complications, you have to go for the test. There's psychological distress, wanting to know the results, do I have liver cancer or not? The financial burden, often you'll have to take a half day off of work. You have to take vacation time. So we have to balance the pros and cons. And then after the balance is how old is the patient? How many comorbidities do they have? And what are the actual goals of care and the patient preference of knowing that they have a diagnosis of cancer, and how aggressive or not do you want to be? And so we recognize that in Calgary. And so we need the literature that anytime I take any person that is eligible for screening, and I say for you, like, Hannah, I want you to do the test. And I see her in clinic and she might say, sure, I'll do it, doctor. But I know that in the literature, only about 30% of the time will Hannah ever do it. And so you ask yourself, like, well, why is that? And so we often break it down into patient factors. So Hannah just said, yeah, to please me, and then, left the room, and let's screw him, and then moved on. Or, there could be actual, like physical barriers. So she doesn't have a ride to take to get the test done at the center that I sent it to, or it's too far. And there may be other social barriers, right? So we classify it into patient, provider, and system barriers. So there's a lot of system barriers, right? A lot of the patients that we treat are from a lower socioeconomic status. And so if I tell them, go get a blood test, go do that, that actually might mean 2 separate days that they have to take off and do that. And so how likely are they going to be able to do that, knowing that they might be fired from the job or so. So we created this program here where we partnered with EFW Radiology, and we took out the provider and the system part of a screening program here and really looked at 10,000 patients. It started since 2013 and it continues to go on there. And we've shown that we have a retention rate of around 68%. So as I mentioned in the literature, at most you can see about only 30 to 40% of people regularly participate. In our Calgary cohort, we have a participation rate around 65 to 70%. Right now, what we're doing, and this one of my research portfolios is looking at what are the long-term benefits of this. So did we find cancer earlier? Did that person get a benefit from being in this program? And so forth. There's so many questions that we can ask regarding that. So we're really lucky to work in Calgary, and this is ongoing. So once we have detected liver cancer, and usually that is done by a CT or an MRI, we often see these patients in the clinic. And so the question here for the audience is, liver cancer can be cured with surgery potentially. And what I mean by surgery is they take out part of your liver. As I mentioned, usually the liver can grow back in about 6 weeks. Local treatments, that's usually done with our radiology colleagues, or even liver transplantation. So what does the group think here today? Okay, I'm a little bit disappointed, but so 86% of people said true. I would want that to be 100%. And here's why. So really, when we look at cancer, we break it down into curable or not curable. Okay. And when we do that, we follow something called the Barcelona Clinic Liver Cancer Staging System. So you don't have to memorize this, but you can see how complicated it is, okay? And so what I want you to remember is the right side of the diagram, where we look at advanced stage cancer or end stage cancer. And those are defined by someone that has a tumor in their veins that are connecting the liver, or it's spread to other parts of the body, i.e. metastatic disease. And then end stage is really the patient is sick and they're not going to get out of hospital. And so when you look at the survival rates, so BSC stands for best supportive care, you're looking at a survival of less than 1 year. Usually at that time, we recommend palliative care. In the advanced stage setting, you're looking at a survival of greater than 2 years. And since 2017, you can see at the bottom there, there's a first, second line therapy with what we call, which is traditionally chemotherapy, but now we call it immunotherapy, which has extended the lifespan of individuals living with liver cancer from a median survival around 9 months. Now, some of the studies that are being published, a lot of people can live up to 23, 24 months on these medications. We have a first line medication. And if you fail that for intolerance or tumor progression, we can move you on to a second line and then even a third line. And then we have clinical trials after that. Now, I want you to center yourself in the middle stage there, intermediate stage 3. And here you can see that it starts getting really complex, and it matters on the number of tumors you have, how well your liver is functioning, how well you're functioning as well. And the goal right now in liver cancer research is actually, how do we move the people that on the right side of the curve to the middle side of the curve, where we can expand their lifespan from around to less than 2 years to greater than 2 years, 3 years. And we can do that from a variety of ways. So we can do something called transarterial chemoembolization, which is through our interventional radiology colleagues. We can do liver transplantation, we can do ablation, we can take out part of the liver, and we can do ablation with probes that can burn the tumor. And if you look at the left side here, where if you catch the tumor really early, we can do less invasive type of treatments, and you can have a longer survival from greater than 5 years. And that's really the expectation. So anytime we see a patient and they're in the middle or advanced stage, at least in my mind, we're trying to say, well, how can I bring this patient to the middle? And then if we get them in the middle, how can we stabilize these patients, even get them to the left side? Sometimes those are Hail Marys, but I think that's the expectation that we should expect and we should strive for. Certainly, it involves, discussions with the patient and to ensure that this is what they want. Some patients rather take the palliative approach, and we fully respect that. But anytime I see a liver cancer, we see as a group see it, we're trying to extend the life of that individual as best as we can. And how do we do that? So in all across Canada, this is really standard of care. And so these are called liver cancer rounds, the multidisciplinary tumor board rounds. So every major city in Canada has these. We usually here in Calgary, ours are Tuesdays from 7 to 8 a.m. We have a interventional radiologist, we'll have a hepatologist, we'll have a medical oncologist, we'll have a radiation oncologist, we'll have a surgeon, we'll have a general radiologist, and some groups even have a pathologist. But here we talk about the tumor number, how's the liver spread outside of the liver, how well are they functioning, what's the status of their liver, and then the size. And we know from literature that whenever cases are discussed at a multidisciplinary tumor board round, that you have a less of a wait time to treatment, you have better concordant guideline therapy plan development, you have increased access to research protocols, and generally patients feel that the experience is better. You may or may not be involved directly, but your care is being influenced by these types of rounds. And this really is what we also try to do in Calgary, is an echo model. So this concept was brought back in 2011 by an individual, Sanjeev Arora, who worked in New Mexico. He found that a lot of his patients with hepatitis C couldn't get to the main center, couldn't get to Foothills Medical Center. So he called this project ECHO, which was trying to enhance care outside of the ivory tower, the tertiary care center, and really develop this hub and spoke model. And so we at our site, we have cases from Medicine Hat, Red Deer, Lethbridge, and we have participants, physicians or nurse practitioners call into our rounds to help discuss tumor board rounds to get the best care. So this is the last question that I have, and what do people think about palliative care, advanced care planning? Offer survival advantage. So not that it's better for you, but you actually live longer because we gave it to you. Amazing. Yeah. So 80% have chosen true. And yes, you're right. And so it likely is true. And the problem is that we're not doing it enough. And so this is a study that we conducted looking at patients with end-stage liver disease, and only about 4.5% of patients had palliative care referral. When you compare that to someone with breast cancer or any other type of cancer, their rate of palliative care referral was much higher, as you can see from the two graphs. And so that poses a big problem for us. And this kind of goes down the chain. And so we know that goals of care are not discussed, do not resuscitate orders are not discussed. And so what really happens is that a lot of these things are rushed in the last 72 hours of a patient's deaths. And so you can see at the bottom here, about 90% of palliative care in the inpatient setting are within the last 72 hours of death. And we know from the literature, when you engage in palliative care consultation and you do parallel care, so parallel care means that you're preparing for the worst, but hoping for the best, and you're getting full medical therapy. But in case things don't work out, you have a plan put in place for you to ensure that your road to death is actually smooth. It's not stressful. It doesn't take a financial toll on your family, emotional toll on your family. And a lot of times when we look at the deaths in liver disease, it's a wave where everyone is panicked, and really that's not the way to die. You wanna have a smooth trajectory towards the end, and you want to make sure everything is settled and everything is calm, and then slowly progress to the afterlife. And this was a big study. It was a survey done among liver specialists in North America. And you can see that our communication with our palliative care colleagues is very low. And there's perception that when we talk about palliative care, there may be some, giving up. People feel scared and anxious, and you start thinking the worst. Like it becomes synonymous with I'm dying, when really that's not the case. And palliative care can actually offer you much more help in terms of developing your goals of care, wishes, sorting out finances. If there's caregiver burden, they can also help with that, and really, again, smoothing out that trajectory. And this was another study looking at early palliative care referrals as part of outpatient transplant appointments, and even just automatic palliative care and interventions. And you can see when we start doing these things in parallel, goals of cares are discussed more. The do not resuscitate increase, and this is a good thing. Withdrawal of life support, the length of stay in the surgical ICUs can reduce as well. And then most importantly, there's this Edmonton symptom assessment scores can really help the patient with symptoms that we just don't talk about in the day-to-day. Although there's no change in mortality, we generally feel that it's worthwhile. So we're kind of at the end of the talk there. I hope you've enjoyed it and learned a little bit something. So, fierce advocate that the liver is the best organ for many reasons. And I think you do too, by the number of participants that are here today. Late diagnosis really is driving mortality and cost to our healthcare system. We have ways to identify and treat patients early, and that can affect outcomes. We know that HCC is a curable disease if caught earlier, and if not, there are still therapies that can potentially lead you to a cure. And there is probably a potential of early benefit of early palliative care. So thank you very much for attending. If you want to know about the Calgary Liver Unit a little bit more, there's a website that we have there, and we can talk about that. Yeah, thank you.
Thank you, Dr. Brahmania. That was great. We will now open the floor for a Q&A session. We'll alternate between questions from Slido and our live audience, and we'll do our best to answer as many questions as we can in the time remaining. And again, please note we can't provide patient-specific advice or individualized medical advice. So to get started, we can call on someone in the audience. You can go in the white vest.
A good question. So for the audience at home, the question was, does liver cancer help once you have drinking coffee, does it help liver cancer once it's been diagnosed? So generally the coffee question has been studied in prevention of liver cancer and chronic liver disease. So once you have liver cancer, there's pretty much not much that you can do aside from looking at targeting the liver cancer and trying to treat the liver cancer. Of course, if there's an underlying etiology that can be treated, such as viral hepatitis, then we would initiate treatment for that. But now our phase or an approach to treatment is more focused on what we would want to do regarding the cancer and less so about prevention. And that's why, again, it's so important to look at the upstream drivers of end-stage liver disease and the downstream consequences of liver cancer. Really, that is the end stage and end of the road. And by that time, although we can do things that can help your survival, it is generally too late, quote unquote. So there's some questions online. So the first question is, you referenced the multidisciplinary treatment panel for developing liver cancer treatment plans. Is this the model used in other cancers as well? And so the answer is yes. This has really permeated all cancer groups and really is standard of care. So if you do know someone that has it or yourself has it, you should at least have your case discussed at one of these multidisciplinary tumor board rounds. So the second question here, are there any supplements that are good for the liver? So the most common ones that we hear about are cod liver. There's a couple other I'm blanking on right now, but generally the evidence for those are mixed. We do caution taking any type of supplements because a lot of these supplements are not regulated by Health Canada, essentially meaning that you don't know what exactly is in that pill. And the issue with that then becomes is that a lot of these can cause a drug-induced liver injury, which can really, lead to liver failure and death. And we do see that quite not uncommonly. And so generally, there's no supplement that can alter the trajectory of your health that we know about at this time. We'll take one from the audience there. Yeah. So our research is really with the liver cancer surveillance program is looking at the systemic effects of programming and increasing retention. I personally feel that we have the tools, but we're not using the tools efficiently enough to do that. And you can see that in the literature across. I think now that we've shown that we can increase retention with the EFW program, the next phase of our program is looking at specific populations that we've seen in our multivariable analysis that show that they tend to drop out. We find that the patients after about 5 years start to drop out, and we don't know exactly why that is. Could it be just from test fatigue, or do they feel asymptomatic, so they feel like they don't need it anymore? And so we're looking and we're going out into the communities to figure out, those patients that were adhering to the program versus not. Well, why didn't you adhere? What were some of the factors there? Did we not explain it to you? Were there social barriers or other economic barriers on that? So we're not really focusing on the sensitivity and specificity at this time, because we know that the tests generally work and they're good enough. They're just not being implemented. And so that's the major issue for us right now. So with fatty liver, the other question is, with fatty liver disease, can this be improved with lifestyle changes? So fatty liver disease was also known as non-alcoholic fatty liver disease. Now the terminology has changed to metabolic associated steatotic liver disease because we don't want to call it fatty liver disease due to the stigmatism. So this individual has said, can it be improved with lifestyle changes? And that is the mainstay treatment for what we call MASL, or fatty liver disease. So diet, so we often get asked what type of diet is the best. And we recommend any diet that is sustainable and is in moderation. The Mediterranean diet has been shown to improve cardiovascular outcomes. So if you can sustain a Mediterranean diet, that is probably the best. But again, these fad diets of high protein or low fat or Atkins diet, we often see a rebound and it's just not sustainable. So we always encourage something that you're going to do. Does it fit with your values? Does it fit with what the rest of your family is doing? So you could be doing a high protein diet, but the rest of your family is eating something differently. Those aren't sustainable things. The second part of it is exercise. So what type of exercise? It can be any exercise, actually. 30 minutes, 3 to 5 times a week is good. Whether this be anaerobic or aerobic, it does not matter. And again, we're looking for something that you can do for a long period of time to make a change. And you wrote the key thing there, which is lifestyle. So we're really looking for a lifestyle change in this disease rather than, a short-term goal of I lost 5 pounds by, March, and then you forget about it. So you want to build this and incorporate it into your day-to-day lifestyle. Yeah, you back there, yeah. Yeah. So the question from the audience at home is, what do you do with the false positive test results from an ultrasound found in the screening program? So you're absolutely right. Like that's one of the unintended consequences of large screening programs. Are you ordering more tests afterwards? And so, there's not a real good question. We know there's harms with that, not only to, health policies, but also to the patient, because now you have to do a CT or an MRI, wait for the results of that. There's not a really good answer regarding that. Again, when we're looking at big, large screen interventions like that, you're always going to have some unintended consequences. And are these something that you want to live with? I think those are just further questions we need to explore. Yeah. So you can go to the Calgary Liver Unit, and on there we do have research studies, or at least what each individual physician is interested in, and then you can contact the liver unit, and then we can let you know about clinical trials that we have. Right now, the Calgary Liver Unit has about 30 clinical trials in viral hepatitis, mostly hepatitis B, which Carla Coffin leads. We also have clinical trials for mast cell or fatty liver disease, alcohol, and rare autoimmune diseases. My research is more population-based research where we use big data. So it's not patient facing per se. There's another question again from the group at home. So the tea also has caffeine, so any positive effect on drinking black tea? Unfortunately, the tea has not been shown to improve outcomes in chronic liver disease and even viral hepatitis. It's actually just the components of the coffee itself. The other question from another individual is comments on the risk of dietary fructose to the development of fatty liver disease. And so that's an intricate question. So fructose is a type of sugar. It should be limited in general as part of the diet recommendation. Anything that's high in sugar or fructose should be reduced to moderation. No one is saying that you cannot have a cheeseburger or a cake, on a Friday night with friends, but having it every day after dinner is probably not recommended. And there's more to fatty liver disease, and we're learning that now as well. It's just not diet. There's obviously genetic factors that play a role into it. And now that we have these new drugs such as Ozempic and Mounjaro, those are playing a role in how we treat patients as well. So really the field of fatty liver disease has moved from just focusing on diet and exercise, although that's the mainstay, to being a more multidisciplinary approach and taking a wider lens onto why that patient has developed fatty liver disease. So it's not specifically eating more fructose, it's the behavior around that. Why are you doing that? Why, why is that diet? Is it due to convenience because you have 5 kids and you're a single mother, right? Like there's so many things that can play a role in that. how does a low-calorie dairy or maybe oat milk addition to coffee negate the benefits of drinking coffee? Yeah, you're exactly right. So no one has really studied that, and it would be very difficult to study the different variations of how you can make your coffee. What we do know from the literature is black coffee alone has been beneficial. Sorry, yeah, go ahead. Yeah, so the question is, what is the difference between liver cancer and liver metastases? So liver cancer or hepatocellular carcinoma is confined within the liver. And anytime you have metastatic disease or hear that word, it's moved outside of the organ that it originated from. So if you had a liver cancer that was spread to the lung, that would be called a lung metastases. Generally, when you have metastases, your prognosis changes a little bit. So is Alberta looking at changing the age of living donor program for 55 years to look at older donors? A very good question there. So the age risk cutoff can vary between programs. And this person is asking about liver transplant. If your partner or friend, whatever, was looking for a liver transplant, you have an option of a deceased organ pool, which is the general pool, which you can receive an organ from, or you can donate part of your own liver to that individual. In Alberta, we do about, at the University of Alberta, they do about 5 to 10 living donor transplants per year. You go to a place like Toronto, they do about up to around 50 living donor transplants per year. There is age cutoffs that we use generally because as you get older, you start to develop more comorbidities. And then the organ that is going to be used is not as pristine as one that is 20 years old and less likely. So there's really strict criteria around there. The mortality rate from living donor transplantation for the donor itself is about 1%. And so you got to think about the risk of the donor and ensuring that the safety of the donor. One of the Hippocratic oath that all physicians live by is thou shalt not do harm. And so that actually can purposely do harm for other individual. So you really got to be selective. And it's not really about per se the age, but it's about the risk. And what is the risk of doing harm to someone that is trying to be philanthropic and, just harming that patient? It's a good ethical question to ask. So how can we participate in research work? If you're seeing a hepatologist, you should always ask your doctor if there's any clinical trials related to the disease that you may or may not have. There's always research going on. If you don't have a trial or something that you can participate, we usually take a patient's name and we keep a database that's secured. And we contact patients down the road if some trials come about. So are there any other treatments for any other kinds of viral hepatitis? So the viral hepatitis, it's a broad field. So it includes hepatitis A, B, C, D, E. Hepatitis A is mostly a fecal oral spread. B is usually maternal to fetal spread in endemic countries. Hepatitis C generally is from blood transfusions or IV drug use. And then hepatitis D actually goes with hepatitis B. And we see that more in the Eastern European countries or even Africa. And so for A and E, we generally don't, we don't treat, it's conservative treatment. B, there's oral treatments that you take once a day for your lifetime. For C, there's a cure. For D, there is treatment now that is coming into Canada based on a trial that was done a couple of years ago. And hepatitis E is very rare. And right now we don't have good treatments for that. think we answered that one. So the other one there, how does the surveillance and screening different outside of Calgary? So the screening is set. We have internationally published guidelines on who should get screening. And we generally recommend that surveillance should be done with an ultrasound and alpha fetoprotein, which is a blood test. The way that we conduct surveillance is what we do different here. And so, as I was mentioning, we have that program to have higher retention rates. Other cities don't have formalized program. So I imagine that their retention rates into a cancer screening program would be much lower overall. But that data has not been proven in Canada, but it has been proven in North America, American literature. So how do I know if I've had vaccine for hepatitis B and C? So there is no vaccine for hepatitis C as of yet. There is a vaccine for hepatitis B. Your general practitioner should be able to tell you. It's a blood test to see if you've developed antibodies for that. To know if you have hepatitis C, again, it's a simple blood test that you can get done, and they would be able to tell you if you have the infection or not. How do we advocate for preventative liver health programming? Liver elastography technology has been around for 25 years. Bingo, that's what we're here today for. And what we're talking about is prevention, prevention, prevention. As I showed in the first few slides, it's incredibly difficult due to politics, government, patients, providers. It's a very complex topic that is very difficult. I would urge you to read that article that we published in the Canadian Liver Journal just about preventing liver programs, and really it's a call to action around that. Hep B vaccine is beneficial. Is this a program recommended and implemented by AHS? It is not available. Well, it's available in the hospital, but it's not formally a plan. This is something that's outside of the hospital system and lies within the primary care environment. And we do work with our primary care providers to ensure that patients are being vaccinated. We work with the refugee clinic, and so any newcomers into the country, we're testing for hepatitis B and providing vaccination for. There's a lot of efforts being taken right now across Canada to ensure that hepatitis B vaccine remains an integral part of care in Canada. Since cancer risk is supposedly high for shift workers, what are things they can do for prevention? And is liver cancer a common cancer for shift workers? I'm not sure of the data on shift workers and liver cancer per se. I suspect, shift workers often sleep patterns are affected, diet could be affected, exercise, and those probably play a role in the type of cancer that is developed more so than per se your shift from 12 to 8 a.m. Does PCOS, this is polycystic ovarian syndrome, affect NAFLD? So there is a direct link with polycystic ovarian syndrome and NAFLD, which is non-alcoholic fatty liver disease, mainly in the form that it really is responsible for being overweight. Many patients with PCOS have problem with regulating hormones, which can lead to being overweight or obese. And then that's where the problems of NAFLD actually arise. So there's a well described link between PCOS and NAFLD. Is there a potential that targeted therapies might be considered in the future in advance of TACE, TARE, and possibly ablation? Yeah, so this is where the field is really moving towards, is toward blood-based biomarker testing to predict which patient will get cancer. So you could see that maybe if we can develop that technology or test, that we would just test you in the blood work every 6 months, like a hemoglobin A1C, or just checking your blood counts every 6 months. And if that biomarker became positive, then we might be moving on to a more advanced therapy. Again, this question, once you have the tumor established and diagnosed, then you're really looking at these types of therapies that I mentioned before. So thinking at the gallbladder fundus, potential liver cancer. No, those are two different organs, although the gallbladder sits within the liver, it's totally separate. But you should talk to your family doctor, as we talked about before. Could you comment on the treatment outcomes for mixed tumors in the liver? So I think what this person is getting at is that there's a few types of tumors that can develop in the liver. The most common is hepatocellular carcinoma, but you can also develop cholangiocarcinoma, which is a tumor of the bile ducts, which is very aggressive. And the third part is that you can have a tumor that has a combination of the cholangiocarcinoma and hepatocellular carcinoma. And those we treat similar to hepatocellular carcinoma. Cholangiocarcinoma is a very aggressive type of cancer. About 80% of people die within the 6 months of that they're being diagnosed. There's new therapies coming out and treatment paradigms that we're working on for that kind of rare tumor group that has very bad outcomes. So this is a question. So is there an increase of liver cancer for those who had a hepatic adenoma removal, who maintain a healthy lifestyle? So a hepatic adenoma is considered a benign liver lesion that many patients have. They can vary in size from anywhere from 1 centimeter to 15 centimeters. We generally recommend that you have a resection or removal of the adenoma once it's over 5 centimeters, because we know that the ability of that adenoma to transform into a cancer is a greater risk. Once that adenoma is removed, depending on the size, then your risk becomes back to zero with a normal liver. And so generally, most adenomas are not removed due to the small size, but if you do have a big adenoma, then they're surgically excised. So it's good, a lot of questions. So in the screening process, besides age and the shared HPV, do you know what other characteristics were taken into account, i.e. habits, frequency of drinking? Yeah, so I think, I mean, this again goes back to visiting with the patient, taking a history, physical exam, reviewing the laboratory work, and putting together a profile of that patient, and then determining what screening they need and what is the main indication. Certainly, I think what you're getting at here is, well, yeah, you have a lot of questions in that one sentence, but you know, not every patient just has one single disease. So you could have a patient with hepatitis B that drinks a lot of alcohol, and that's also overweight. But you know, if they're 42-year-old female, they're eligible for screening just based on their hepatitis B infection. And if they didn't have hepatitis B, and then you would have to look at, you know, how bad is their liver disease and are they eligible? And so again, you know, when you talk about age as well, if I saw someone that was 95 years old, I would really ask myself, do you want to do that? And certainly there are robust 95-year-old, but again, you have to think about, is this worth their time, effort? And then even if we did find the cancer, are they likely to do anything? And generally, as you get older, you're less interested in aggressive treatments. So the last question here, I think, unless there's some from the audience, for surgical procedures, is there a different perioperative care procedures depending on the likely reasoning surrounding how the individual got? So in short, that's called bias. So we do not do that. Or we try not to. Obviously, people come in with their own biases, but we look at the patient as the whole. Doesn't matter gender, race, ethnicity, age. You look at it as a static thing. And so I don't know what the experience was here, but we don't differ in our approach in the treatment. And that's also back to why we use multidisciplinary tumor board rounds, is to take out that bias that you may carry within yourself and have different colleagues help you interpret and make sure that you're in the right line of reasoning. And everyone's prone to that. And so these rounds really help. And you know, it's not uncommon. We're like, oh, I just didn't think of that, or a good idea, right? And you got to be open to that for the best for your patient's care. So, you know, the short answer is no. But I don't. Oh, there's one question there. Yeah, go ahead. Yeah. Yeah, sorry I didn't clarify that. So the question is, what did I mean by saying endemic country? So we know there's certain countries in the world that have a higher prevalence of hepatitis B or viral hepatitis. And those countries are India, China, parts of Africa that have that. So whenever there's migration, you want to screen, make sure that they don't have the infection. It's not part of the policies for immigration to check those viral hepatitis, but often these patients are linked into a clinic, linked to a primary care provider, and often it's the refugee clinic, and there we're able to screen these patients. And so that recommendation is really for primary care. And if you have someone that's come to you from an endemic country, you might not think about to test, especially if there's other issues that you're dealing with. And so it's a recommendation rather than a target to say, hey, everyone from India should be tested for that. It's not a little bit more intricate than that. It's about what are the risk factors, where they're from, is there any family history, and just to be aware that there's a higher prevalence of hepatitis in these countries, just because of you know, society, right? Okay. Wow.
Well, thanks, Mayor, so much for speaking tonight. And thank you, everyone in the audience, for attending tonight's lecture. I'd also like to thank our collaborators, Buxa, AstraZeneca, the Cummins School of Medicine, and the Calgary Public Library for their continued support. We hope that you enjoyed tonight's lecture and invite you to join us on March 2nd for our next lecture. For those of you here in person, please join us to connect over refreshments in the Hippocrates Atrium. And for those of you online, thanks again for attending and have a great evening.